but I know we have a lot to discuss today. This will be a really interesting talk, so I want to jump right into it. So thank you so much, everyone, for joining us today. My name is Laura Ferrer-Legier, in case you don't know me, and I'm the Senior Manager of Public and Community Engagement at ICS. As you may know, the ICS Equity and Focus Speaker Series is a virtual event hosted by the Science Office to share theories and practices around using race and related data at ICS. Today, we'll be focusing on the Community Health Center, or CHC data, available at ICS. We will describe and contextualize the available data that we have, provide considerations for use, and dive into an ARC case study example led by the Black Health Equity Working Group. Before I introduce all of our fantastic speakers for today's session, I want to open with a land acknowledgement. So as you know, ICS is based in Toronto, which is covered under Treaty 13 and the Williams Treaties, and is the traditional territories of many First People, including Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. This territory is part of the Dish with One Spoon Wampum, a treaty made between the Anishinaabe, Mississaugas, and the Haudenosaunee, where nations entered into an agreement to protect the land and responsibly care for its resources in harmony together. As we gather today, these nations continue to experience ongoing colonization and displacement. We recognize our responsibilities to engage in meaningful, continuous process of truth and reconciliation. Although we'll not be discussing Indigenous identifiers within the CHC data we are speaking to today, I want to also highlight and acknowledge that there are 10 health access centres across Ontario that also provide Indigenous-led services to their communities, including a combination of traditional healing, primary care, cultural programs, health promotion programs, community development initiatives, and social support services to First Nations, Métis, and Inuit communities. I'll now introduce our speakers today. And for the sake of time, I am reading abbreviated bios, but I do encourage you to refer to the meeting invitation to see the complete list of bios for all of our 4 speakers today. Angela Robertson is the Executive Director of Parkdale Queen West Community Health Centre. Angela is dedicated to people and communities facing discrimination, poverty, and marginalization, and working to change those social conditions. In response to the impact of the COVID-19 pandemic on racialized and low-income populations, Angela initiated and co-chaired a Black Health Equity Working Group of health sector experts, leaders, practitioners, and researchers concerned with improving the health and well-being of Black people. Cynthia Damba is the Director of Health Analytics Team at Ontario Health Toronto, with over 25 years of experience in population health surveillance, healthcare system planning, performance measurement and evaluation, health equity, quality, and health workforce planning. She has co-led and helped to spearhead the collection of use of standardized equity data collection in Toronto region to improve health inequities. Originally a physician in East Africa, she did her master's in community health and epidemiology at the University of Toronto. Dr. Jennifer Rayner is the Director of Research and Policy at the Alliance for Healthier Communities and supports over 100 community-based primary care organizations in Ontario. She's an applied health services researcher with interests in primary healthcare, interprofessional teams, health equity, and learning health systems. She is a research professor at Western University within the Centre for Studies in Family Medicine, an associate professor at University of Toronto, and a scientist with ICS. Leslie Plumtree is a staff scientist with Data and Analytics Services, or DAS, and the Life Stage program at ICS Central. As a staff scientist, Leslie supports requests from external knowledge users through the Applied Health Research Question, or ARC program. Leslie completed her PhD in Nutritional Sciences at the University of Toronto and Master of Science in Nutrition at King's College London. So thank you so much to all our speakers today. And without further ado, I'll hand it over to Dr. Rayner to get us started for today.
Thanks, Laura. So if we could go to the next slide, I'm going to take a little bit of a step back in time because this is how our data standards were developed. So this picture is what we refer to as our model of health and well-being, and all Alliance members have adopted and endorsed this model, and it's really our roadmap for service delivery. So it includes data standards, which I'm going to get into the next slide, for every type of provider, and it's really just it includes stuff like interprofessional care, determinants of health, population needs-based, and it's sort of all of our different components of how we work as community health centers and the values that sort of underpin everything we do, which is health equity, community vitality, and community-centered care. I've put a link to a paper, so if you're interested in learning a little bit more about the model itself, there's a link there for you to give it a read. So next slide. So from that model of health and well-being, we've created an evaluation framework with specific data standards that really demonstrate this CHC model of health and well-being. And this is what we're going to be talking about today. So it includes client characteristics, including sociodemographic and race-based data, individual encounter data or visit data. And I'm going to get into detail about this, but every provider, whether you're a physician or a dietitian or an outreach worker, collects individual detailed data that's all standardized and coded, reflecting the types of encounters and the issues they're addressing. All of this data sort of at a high level goes into a data warehouse, and we have a common set of process and outcome indicators that are all, again, mapped to that model of health and well-being. So next slide. So this data was built because CHCs were invisible in the health system. So an important characteristic of community health centers is that they're a salary-based model. So that means there's no OHIP billing that describes the work that the physicians are doing. And of course, there was nothing that described what the teams were doing. So way back in 2000, again, we built this evaluation framework and we really took control of our own data. And I think that's a really key part of what we do, because we came together as a sector and said, this is what we need to do as a sector. And we mostly use the same EMR, which has made it pretty easy to implement those data standards. And we built a data warehouse. Now, back in 2009, I was attending a public health conference and I saw Dr. Rick Glazier speaking about his work on diabetes and poverty. And I was doing my master's at the time, and I emailed him and said, Dr. Glazier, do you realize you're not including the CHC data in this work looking at poverty and diabetes? And of course he did. And so I said, well, if I can get this data to you, can we start including, the folks we serve in community health centers into the work of ICS? So, I mean, it was a real labor of love, I think. And I manually collected the data from every community health center, coded it, and literally almost carried it to ICS. That's why I like this picture. Now it's much easier because we've got our data warehouse and we basically push a button. But for me, it was so important because, we see the folks that experience the most barriers to care, and they were being excluded from all of these big population-based studies and policy studies. And so, again, it was sort of a labor of love. So we've got a data extract that's grown over time, and I'm going to be talking about that. But it really started at about 2009, 2010. So if we go to the next slide, this is just sort of a walk through what we've done. So in 2010, we worked in collaboration with ICS to develop a longitudinal data set that included nurse practitioners and physicians. Now that's a key point to our data because nurse practitioners carry their own panels. They kind of work side by side with the physicians to be primary care providers working to full scope within community health centers. Now, at that point in time, we created a project-specific data set, and that included a project that would help us understand what we were doing. So it was we did a comparisons of model study, and we created what we called practice reports, which have now kind of become mainstream, and we're doing these practice reports every year. In 2018, we started bringing in all of the team-based data. So we've got, again, all of those other interprofessional team members. Data is now at ICS. And we included our sociodemographic and race-based data, which is really the purpose of this conversation. We also changed the data to be a controlled use data set. So there's a form you can fill out to use the data, and that form comes to me. I give it a quick review to make sure it makes sense and make sure you don't need any help with sort of figuring out the data. And quite often, I mean, it's just approved very quickly and you're on to your project. In 2024, just to give you an idea of what's happened, the interest in the CHC data is growing. So we did a count, and there was 60 requests last year to use the data. There was only 4, though, that used the specific team-based data. So I think that's something that we can really delve into at the end of this conversation. How do we really use this sociodemographic and race-based data, as well as the team-based data to understand the full complement of what we're doing? And now we're working with other places. So our data is also going into Poplar and one of the 7 practice-based research and learning networks. It's going to Chi-Hi, it's going to the ministry. So we're really getting that work out there, but ICS was the first. So if we go to the next slide, I'm just going to walk you through a little bit of the clinic workflow so you understand how the data works. So what we've done is we've tried to sort of standardize data that represents the clinic workflow. And so we have patient details entered into the EMR registration, which includes the sociodemographic and race-based data. And again, every visit a person has with a provider, regardless of who that provider is, again, physician, nurse practitioner, social worker, outreach worker, records that standardized data into their EMR. And all of that EMR data goes into our data warehouse nightly. So we move to the next slide, we'll get into sort of the nitty-gritty of what's included. So the client determinants of health data, or sociodemographic and race-based data, includes sort of the usual registration data, so date of birth, address, postal code, and health card if applicable. Their gender, their sexuality, whether they have a disability, their identified race, country of origin, year of arrival, their preferred language of service, and we also collect the inclusive definition of francophone, household income and number of people supported by that income, the highest level of education achieved, and a bunch of social needs questions. Now, those social needs questions are fairly new, so the data completeness, we're sort of getting there. We just implemented those social need questions last year. We go to the next slide. I'm sort of whipping through this, but you can find me pretty easy for more details. So then we have the encounter level details. So again, this is for every visit a person has with any provider within the CHC. It includes the date of contact, the provider involved. So all of that's coded. So you've got physicians and nurse practitioners, outreach workers, social workers, etc. The diagnoses, or what we call issues addressed, because sometimes some providers wouldn't be doing a diagnosis per se, but they're actually talking about, social isolation or precariously housed or food insecurity. So we've got codes for all of that data, and it's all mapped to ICD codes. Then we have a whole bunch of services that are coded, procedures, immunizations, referrals, and a bunch of other data that sort of codifies that encounter detail. Next slide. Another piece of data that I thought you might be interested in is we've got this grouping for the community health centers that we refer to as peer groups. So we developed this peer group methodology just to ensure that CHCs could sort of learn from each other, because sometimes geography just doesn't cut it. So for example, if you're a high-risk urban CHC, you may want to compare yourself amongst all the other high-risk urban CHCs in Ontario. So we decided to put this data into ICS, and we've used it a few times. So I've done some projects with Dr. Gutman and Dr. Glazier, both that we've used these peer group methodology, and it's a nice way to sort of cluster CHCs into groupings. So I'm going to talk a little bit more about the data quality and the nuances of the CHC data. So as you can imagine, starting back in 2000, when we created that model of health and well-being in our evaluation framework, we had a really strong and long commitment to health equity. And one of the way we operationalize that is to collect usable sociodemographic data. Now, we were sort of chugging along in 2000, collecting this data, but at an annual general meeting we had in 2020, the executive leaders passed a resolution that we would make a commitment to collect sociodemographic data as a sector and really ensure that we collect that data to a high standard and use that data to identify health disparities. So they set a goal that we'd achieve 75% by 2024. Now, this goal of 75% became our burning platform, and it gave me the leverage to get as many teams to improve their data collection completion rates. So you can see on this slide that it was hovering around 50 or 30% for some of the data groupings that we had originally identified as being so important. So just quickly, if you go to the next slide, good news is we did a learning collaborative. We used the IHI model for improvement. We had 30 teams sign up, and it sort of got a life of its own, because then people started really learning from those teams. So not only the 30 teams, but all 75 teams started taking some of the lessons learned, and we've really improved the data completion rates for those data variables. So as of March 31st, 2025, the data you've most recently got at ICS, we've met our 75% completion rates for household income and education, and just over 65% for items like race, sexual orientation, and gender. So still a ways to go, but we're really working hard. So I've got one more final slide. I know we've got a lot to get through, but I just wanted to give you a few sort of notes about the CHC data. A really important one is that CHCs see people without health cards. So about overall 14% of the CHC clients do not have an OHIP number. Now, that doesn't seem like a lot, but when you get down to the individual CHCs, it could have a huge impact on their data. So up to 56% of some CHC's data is excluded from ICS work because they don't have a health card number. All that data goes into ICS, but because they can't be linked, we end up excluding them. So just so a big important caveat. The CHCs do not formally enroll patients, but they do see physicians and nurse practitioners. But some of these people may be enrolled elsewhere. So we've developed some strategies to deal with that. So again, feel free to contact me with any questions. Nurse practitioners very much carry a panel of patients. So if you don't include the nurse practitioners in your projects, you're going to be excluding out about half the patients that receive primary care at the CHCs. The teams that work in CHCs provide collaboration and support to physicians outside of the sector. So this is something that we often refer to as team care. They work with physicians without access to teams, and they share their team resources. Multiple diagnoses or issues addressed are entered per visit. So another really important note, because we serve people with barriers to care, we often max pack those visits. So we have lots of issues addressed during any one visit. And our kind of timeliness of encounters are based on those serving people with multiple issues. Data is extracted and sent yearly or twice yearly, once in April. So you just received the March 31st data and again in October. And I've got a link here to the CHC data dictionary. Just one more little caveat is when you look at the disease cohorts and some data that's pre-generated or pre-available at ICS, it doesn't often include CHC data. So again, we just have to make that as a note, and often you have to follow the same methodology, but you can add that CHC data to really get a full picture of what's going on. So I'm going to turn it over to Angela so she can talk about a case example of how we use that data in a vaccine strategy. Thank you so much.
So thanks, Jen, for setting that frame. And I just want to kind of amplify why there is significant importance in the collection and utilization of race and sociodemographic data, and speaking to the why. So the why in terms of from the moment of COVID, when we had that faithful March announcement in 2020, that many of us felt that we anticipated that those populations who would be significantly and differentially impacted would be racialized populations, low-income populations, and we were concerned that we wouldn't be able to focus our strategies without having that data. So we, as a small, I would say probably I would say a band of rebels, I would probably say, Black Health Work Group came together to push the province of Ontario and the city, the public health units, to begin to collect race-based data specifically in relation to COVID rates. We had some tussle, I would say, in the early part where there was a sense from the province chief medical officer of health that there wasn't really a particular need right now for us to consider the collection of race data, because regardless of race and ethnicity or background, that everybody hold equal importance and would be equally supported. We continued because we knew that there would be a differential impact. And in fact, what revealed itself quickly within the early days of COVID is that we saw in Toronto, specifically, we saw high rates of Black populations being impacted 3 times in terms of higher rates of infection than their white Torontonian counterparts, that we also saw higher rates of hospitalization, and that the ICS data of 2021 showed that we had high rates, percentage positivity rates, that in particular neighborhoods, and that those particular neighborhoods had the lowest vaccination rates. So that led us to really advance one, and it affirmed why the collection of that data, race-based data, becomes important, because it could immediately reveal where the sites of inequalities lie. And then simultaneously, it can enable us to really focus strategic interventions and real-time interventions that can address those sites of inequality, and which is what emerged as a vaccine equity strategy, because us as a network of community health centers using that data, were able to then mobilize vaccine equity strategies that then brought vaccines into communities, into FSAs, with communities where you had higher rates and higher percentage of Black populations impacted by COVID, targeted vaccine strategies that then we saw significant increase in the vaccine rates for Black populations in those neighborhoods with high rates of COVID. And then we saw lower rates of COVID in relation. So that was just one example of how the data why the data was important, how the data was enabled to be used, and how immediately we were able to see immediate impact and positive impact as a result of the utilization of that data in the context of COVID. As a sector, we know that in the quote unquote COVID recovery, there continues to be significant importance in having this data to ensure, again, that we overlay an equity lens in the recovery strategies and in all of the transformation strategies that we are seeing being advanced currently. So right now we have a primary care action plan strategy that is being advanced here in Ontario, and we're also integrating and advancing in that a population lens as well, recognizing that we know that access to care for racialized Black populations have a direct impact on the outcome in terms of improvements in care. So just wanting to kind of share those elements with you. And I think it's Cynthia. Is it Cynthia who is next? No?
Actually, yeah, I'll take over. Thank you, Angela. Yeah. So yeah, thank you again for laying that foundation, Jen and Angela. I'm here today to talk about the work that was done at ICS with the CHC data set, with Jen, Angela, Cynthia, and team, really focusing on kind of the descriptive analysis that we did with a lot of the race-based and equity-based variables in the data set. I've listed the team members here, but I just want to highlight and thank Eliani for doing the analysis. So next slide, please. So this ARC was submitted by the Black Health Equity Working Group in collaboration with Ontario Health and Jen Rayner from the Alliance for Healthier Communities. The rationale was really that the COVID-19 pandemic exacerbated delays in care, especially in marginalized populations. And the 2 priority areas that were identified by the provincial Black Health Plan included surgical wait times and preventative cancer screenings, specifically breast, cervical, and colorectal. So the main objective is listed there, which is looking at both surgical wait time and cancer screening rates in those who are CHC clients and then a non-CHC client population. So today, like I said, we're going to focus on the descriptive characteristics and what the CHC data can offer. Next slide, please. So this analysis was a repeated cross-sectional analysis. We looked between fiscal years 2018 up to April 1st of 2022. We have the two populations of the CHC clients, which is broken down by self-identified race using the racial ethnic group variable, and then a non-CHC client population, which is a PC-POP-based cohort. So the CHC clients were identified as having one or more physician and or nurse practitioner encounters. So this is where, as Jen was mentioning, that we have more than just OHIP billing physician information. We have lots of different providers that are found in the CHC data. So they had an encounter, at least one, in a CHC in the prior 2 years. And then we use that variable to categorize into self-identified racial groups. So self-identifies as Black, self-identifies as non-Black racialized, white, and then we kept a missing race data category just because it did make up a significant portion of the data itself. And then the general population, as I mentioned, was a comparator group. We matched 4 to 1 to those who self-identified as Black on sex, birth date within a year, and geography, in this case, FSA. So it's worth mentioning that we presented this work in several times actually to frontline CHC staffers, as well as community stakeholders in various times in 2024. This was also featured as one of the sessions for the 2024 ICS Research Forum presentation, which I've provided the link there. And I also did a poster on this work at IPDLN in Chicago last fall. Next slide. So now we're just going to get into some of the characteristics. So just to get you familiar with the table, the columns represent the CHC clients, which are divided into the self-identified racial groups. And then the final column on the right is the matched non-CHC population derived from PC-POP. At the top, you can see the sample sizes for each. And you can see that the largest group with almost 172,000 was those that we couldn't categorize into any of the groups because we had the missing race information. We ran the analysis in 2023-2024, and the unavailable race data ranged from about 62 to 67%. But as Jen mentioned, that has declined significantly, and there is less missingness in this variable and the other sociodemographic variables in general. Then I just want to point out a few characteristics within the table. So the median age for those who self-identify as Black is 37, and that's similar to other CHC groups, but those who self-identify as white were much older with a median age of 51. And there's also a higher proportion of females in those who self-identify as Black compared to those in other groups. And we'll want to keep this in mind when we talk about some of the later slides and some of the characteristics. In terms of income quintiles, there are differences amongst the distribution in the self-identified racial groups. All CHC groups are overrepresented in the lowest income quintile and underrepresented in the highest income quintile. And we also did the Ontario marginalization dimension for material resources. And this measures access and attainment of basic material needs, such as percent unemployment and percent without a high school degree. And similar trends we're seeing here as income quintile. All the CHC groups are underrepresented in the least marginalized quintile and over in the most marginalized quintile, with the steepest gradient from low to high in those who self-identify as Black compared to the other groups. Next slide, please. So here's some equity-based measures that are only found in the CHC data, which we've characterized just for the CHC groups. So gender identity is captured. However, I did mention that the level of missingness is higher in those with missing race data. It's also important to note that gender identity can change over time. However, the data is meant to be updated periodically with a minimum of every 3 years that this data would be kind of checked or updated. Primary language spoken varies across the racial groups. those who self-identify as non-Black racialized had the highest proportion of primary spoken language other than French or English. And at the bottom, that urban at risk refers to the peer groups that Jen had mentioned earlier. So those are located in major urban geographical areas that serve priority populations defined by homelessness and/or mental health and substance use challenges. And other peer groups that are included focus on francophones, newcomers, and rural and urban locations. The breakdown of CHC types that's seen here, with those who self-identify as Black having a higher proportion of visiting CHCs focused on newcomers compared to other racial groups. So that's 30% compared to 11, 3, and 8% in other groups. Next slide, please. And building off the newcomer CHCs, 36% of those who self-identify as Black arrived in Ontario within the past 10 years, which is higher than the other groups identified. About 3% of the population were flagged for recently experiencing homelessness within the past year. And this was similar across the CHC groups, but you can see in the non-matched CHC population, this was much lower. And then in terms of primary care visits, using the OHIP physician billing data, which again was mentioned earlier, that there is some crossover between seeing physicians who bill OHIP and seeing physicians who are at a CHC. There were about 2 to 3 visits to a primary care physician for a set of core primary care fee codes. But when we use the CHC data, the average number of visits to a nurse practitioner or physician was about 8 visits. Next slide, please. So these next 3 slides are more equity-based variables that are found in the CHC data that we've added for illustrative purposes, actually specifically for this presentation. So they include level of education, household income, and household composition. They're added to show what's available within the CHC data, but like I mentioned, it's important to remember that these get updated periodically, so a minimum of every 3 years. So they may slightly differ depending on a client's, say, current status. For all the variables, we left the categories as is, so we haven't combined any categories just to show what's available in the data. So here for level of education, there is a grandfathered post-secondary equivalent category, which is separate from individual ones like college, bachelor's degree, and postgrad categories. There's also a category for too young for primary completion. So it's important to consider the proportion of the population that falls into this category when you're thinking about, the proportion of people who have the opportunity to complete higher levels of education. Next slide, please. So this is household income, and they're broken down into set dollar ranges that are outlined here. With the exception at the bottom, there's that 60,000 plus grandfathered category. So this is just an older income cut point that was available in the data. The number of people this income is supporting can be extrapolated when you combine it with the household composition, which if we go to the next slide will be outlined there. So yeah, here's household composition. Like I mentioned, this information is captured and updated at least with a minimum of every 3 years, so it can change. And like the other demographic-based variables, when we did have missing race information, it was correlated with having a higher proportion of missing demographic information. But the efforts, there's been huge improvement in data collection initiatives. And so that, as Jen mentioned, that information is improving in terms of its level of missingness. Next slide, please. So here's a list of select conditions that we included, chronic disease conditions. We all know that ICES has our chronic disease cohorts that are readily available and are, super efficient and useful for many of our projects. But like Jen was mentioning, if we're working with a CHC-based cohort, that information of all their visits that are obtained within a CHC, it would be something that we would really want to make sure that that information was supplementing any sort of chronic disease that we were characterizing for the population. So for all of the conditions listed, CHC data was included in those as well. For diabetes, hypertension, dementia, congestive heart failure, and mental health visits, all the CH groups had higher prevalence compared to the non-CHC population in this table. And then those who self-identify as Black had the highest proportion of those flagged for HIV, but the lowest flags for COPD, asthma, and substance use. And compared to other groups, those who self-identify as White had the highest proportions of rheumatoid arthritis, hypertension, COPD, asthma, congestive heart failure, substance use, and mental health visits within the previous 2 years. Next slide. So this is a condensed version of the results. We focused on the cancer screenings because for the surgical wait time data, it actually, the proportion that had a surgery was quite small, and so there was a lot of noise. But we did cover those results fully in the ICS research forum presentation, which I've put a link there. So today we're just going to briefly go over the cancer screening rates. In all three of these colorectal, breast, and cervical cancer plots, you'll notice the dip in the data from the onset of the pandemic. You can see as of the last date on the chart, which is April 2022, we hadn't quite fully recovered in terms of cancer screening rates to pre-pandemic rates for all three of the screenings. For colorectal screening pre-pandemic, rates for those in CHC clients who self-identify as White and self-identify as Black were actually somewhat similar and higher than the other groups. At the onset of the pandemic, rates dropped for all, but less so for the self-identified White group, and screening rates remained higher up to April 2022. And the clients who self-identified as Black had a larger decrease during the pandemic and actually didn't quite bounce back as quickly. For mammograms, there you can see a similar pattern with the pandemic onset and then never reaching fully back to pre-pandemic rates. But the trend suggests that CHC clients who self-identify as Black had consistently higher rates of screening compared to the other groups, and this remained true post-pandemic. I should say the onset of the pandemic. And then finally, for cervical cancer, trends suggest that the CHC clients, irrespective of the racial group, had higher rates of screening compared to the matched non-CHC primary care population. So again, I'll steer you towards the full analysis when we went over all the results in the ICS research forum. But this part concludes the ARC results that we performed with the group, and I will pass it off now to Cynthia.
Thanks, Leslie. Good afternoon, everyone. Can you hear me?
Yep, we can hear you.
Okay, thanks. So I'll be talking about the implications of this ARC request research, as well as next steps in terms of equity data collection. As you may know, reducing health inequities is one of the top priorities within Ontario Health's strategic plan. And there's a focus on improving equitable outcomes and experiences for equity-deserving communities. We have published and used several frameworks and plans to prioritize equity, inclusion, diversity, and anti-racism, such as OH, EI, DAR framework, and the Black Health Plan for Ontario, among many things. An underlying foundational element is the collection, reporting, and use of equity data. Much of this builds on the work done in Ontario Health Toronto around equity and equity data collection, as you've heard described by Jane and Angela previously. So it's great to see these results, the results of this project. They really confirm that race-based data and equity data can help to identify the inequities in our society, provide direction for improvement of healthcare for racialized groups, and help to monitor progress in reducing health inequities. The goal is to improve healthcare access, experience, and outcomes of patients. CHC equity data collection is a best practice, and it was able to identify gaps in care related to cancer screening. The results can be used by CHCs for direct patient care and program planning, as you've heard from Angela and Jen. And this data is also useful for us from a health system planning perspective to improve pathways to care, such as those outlined in the Black Health Plan and provincial priorities, such as the Cancer Plan 6 and high priority communities and primary care. The training of data can be used for evaluating of projects and funding and to see longitudinally if we are really achieving the progress we intended. If we put in investments, are we seeing the outcomes improve for those populations we are targeting? In addition, the CHC equity results indicate benefits of the CHC model of care. As Leslie pointed out, we saw higher rates of breast cancer screening and higher overall screening rates of CHC clients for cervical cancer. This could help inform where investments can be made for primary care and prevention services. Next slide, please. So in terms of the next steps for this work, it's important to expand equity data collection to other healthcare system areas to obtain a whole system view. Currently, Ontario Health Toronto has focused mainly on the collection of equity data in the CHCs and hospitals. There's been expansion, some expansion in some other areas, but Ontario Health overall has some areas they're targeting. Another important thing around collection and use of equity data is the importance of education for all the people collecting and using the data, and for the community as well. Training and providing adequate resources to support proper equity data collection and use. Proper engagement of the community and stakeholders in all parts of the process is crucial, as well as public reporting of equity results for awareness and accountability. Leslie talked about the engagements with different groups that was done with the ARC data to understand the data, which is crucial. The CHCs have been leaders in the collection of equity data for many years, with the Alliance supporting to standardize the collection. We thank CHCs and the Alliance for their leadership in this area. There are many resources on their website, which are beneficial for both CHCs, but also other organizations that are embarking on this journey. Lastly, with the project, this project can also serve as a model for ICES continued expansion of collaboration with community organizations on more ARC projects. We thank ICES for their leadership in this area. I'll end by saying I will share the ICES team with the ICES team a slide with the links of the various Ontario Health and Ontario Health Toronto documents and resources related to equity. Thank you.
Great. Thank you so much to all of our speakers. That was a really great overview. And I know, as you mentioned, you've kind of presented this in different capacities, but I think this is also really helpful just to give us a little bit closer look at some of the CHC data involved, and again, some of the implications for future work as well. So we do have some time for questions and answers. So I know we have Mentimeter open as well. I welcome you. You can enter any questions in the chat, or you can just use the raise hand function, and feel free to ask our speakers any questions today. I know there was one comment, Jen, I think when you were speaking, someone in the chat had mentioned they're interested in rehab health professions data.
Yeah, for sure. And maybe while people are getting their questions, I had a last slide that just talked about some of the potential uses of CHC data and sort of some next steps. And I like to think of the CHC data. Now, I know I'm working with a bunch of like really smart ICS scientists, so I don't need to talk about data like a Rubik's Cube, but that's the way I talk about it with CHC folks sometimes. It's a relational database. So we've got information about clients, we have information about providers, and we have information about encounters. And for me, you can shake that Rubik's Cube any way you want to get what you want. So We do social prescribing in CHCs, so we can understand the care pathways between primary care and social and community. All that data is there. You can look at the characteristics of who's accessing care and the types of care pathways that people are using. The role of social workers or like rehab health professions, like the chat said. We're doing a current project right now that's really, in my mind, kind of building off what Leslie just presented, but we're looking at the francophones and we're looking at mental health and service utilization for francophone populations in CHCs. And if you can imagine, you can do this for any type of individual level client characteristic, because we can look at anything that we've got within those groups to sort of define different characteristics of people and look at their care trajectories.
That's great. I will say, I see there's a question in the chat. One also came through the Menti, and it just asked, sorry if I've missed it, how many unique people are in the CHC data holding?
Yeah, so it depends on how you look at it. So if you look at sort of primary care patients, so only those that are getting their primary care at the CHC, it's about 350, 400,000 per year, usually we look at 1 or 2 years of data. If we look at all of the CHC clients, so those that get their interprofessional care teams, it's more about it's higher, like it's like about 700,000.
Mm-hmm.
But you have to remember that they might be getting their care elsewhere in the province as far as primary care goes. But all that data is there.
Mm-hmm. Mm-hmm. There's another question that popped up. Oh, there's a couple coming in now. So the next one I see is, can you discuss data available within the CHC database regarding newborn feeding, breastfeeding, and mental health screening, interventions, etc., well baby visits, etc.? Thanks.
Yeah. So I think the best way to do that would be to look at a group of kids or a group of people that you're interested in, and then look at the service data. So within the service data, we have all sorts of service codes, such as well baby visits, all the screening tools, mental health sort of service codes that you would be able to pull, as well as all the issues you address that are again coded using ICD codes. So all that information is there. We would just sort of need to know what to look for, which I'm happy to help with, but it's that service data, I think, that would be key, as well as those ICD codes.
Mm-hmm.
And maybe types of providers.
Mm-hmm. That's really helpful. Another one in the Mentees asks, have there been any geographical related analyses looking at CHCs in the north versus CHCs in the south in terms of access, population, composition, key health issues, etc.?
Yeah, we did a geographic, so we used those peer groups. Now we looked at people with a rural geography. So not quite northern, but we looked at rural, remote, and northern geography. So that would be probably the closest, I think, that we've got with that data. And that's on the, it was an, I think it was Rick Glazier was involved. I think it was an atlas, and I could find the link as I'm, when we go to the next question, and post it into the chat. But it's on the ICS in the library, and it's geographical patterns for CHC clients, and I'll find it and put it in the link. But definitely, we could do that. Also with the postal code data, we could do that.
Mm-hmm. That's great. I see, Leslie, you replied to a question as well, just about the CHC clients flagged as homeless.
Yeah, and actually it kind of prompted updating the concept dictionary entry that said ICS for homelessness. I know the original paper didn't include CHC data, but there is an algorithm now that includes the CHC data, so that was included.
Really helpful. Great. Oh yeah, and you just posted the link as well. Thanks, John. Give me a few more minutes to see if other questions trickle in. Just to also speak,
sorry,
I think,
maybe if I can add
yes,
on to Leslie's point, I think it's the 2 to 3% for homeless, and those are the ones who are linked with, who have the OHIP numbers, right, Jane?
Mm-hmm.
So this doesn't include all the other patients who are seen by CHCs or clients who are seen by CHCs who don't have OHIP information. So
yeah,
you
that's
may
a
see
good point.
a higher proportion. Maybe you may see, I don't know, Jane and Angela can speak more about that.
I mean, do you want to speak, Angela? I think that absolutely, Cynthia. We're missing a lot of those
Yeah.
folks by not having health insurance numbers. And like I said, the data is available, it's just not linked. So you can only get part of the picture.
Yeah, and I would just add that it is also within that cohort of the uninsured that you also see some of the complexity in terms of in relation to income, racialization, and other identities. So if you even just pull that out as a specific group and do some analytics there, is you will see some of the sites of inequalities that, and because I'm on the service end, I'm always looking at, okay, so this is the data. Now, what do we do in terms of intervention using the data? So that's where, I always kind of go to is you can have brilliant data, but if there is nothing that is done with that, is then it just is information that's not paired with action. So always looking to having the information and simultaneously developing a plan of action. And particularly when we're looking at the utilization and or the collection of racialized data, is that racialized populations, marginalized populations may sometimes, we've heard, hesitancy, questions about providing that in terms of identity data, but it's usually not because people don't want to provide the information, but it's folks want to also understand what will the information be used for to bring about improvements either in access, outcomes, etc. Because we have seen in other spaces, in other geographies where they have a brilliant data set, but not necessarily paired with action for change or improvement.
Thanks so much, Angela. I think that's a great point too, and it just speaks to a lot of the engagement effort with this work, and even all the kind of the knowledge translation dissemination that I think you folks have done after the presentation as well. I think that's been really, really important to highlight too for other projects that are kind of interested in going down a similar route with this.
I mean, as an example, within all of the community health centers, they've prioritized equity stratified cancer screening as part of their quality improvement plans that go to OH. And I think that's something that really speaks to the actionability that Angela spoke to, because once you understand if there's any health disparities, then they can tailor their service delivery to actually reach those populations. And so everyone has kind of shared that and said, let's make that a mandatory indicator for our quality improvement plans across the province.
Fantastic. And I think it speaks again, Jen, I know you had presented a little bit on some of the missingness and again, like the strategies for reducing that. So I think that's great. I think another question just came in. Let me read this one. Can you speak to how CHC data can be used for people who move from uninsured to insured over time, like for newcomers? Does one's data from an uninsured period get linked retroactively to an IKN once they become eligible for OHIP?
Yeah, so we always pull 2 years of data retrospectively, and I know I'm not saying that properly, but we always send 2 years of data to when we go backwards. So we're always pulling all the data that we've previously submitted, and it uploads any new data. So as people get health card numbers, absolutely, they would be included into the data set, and all of those encounters would be included. There's a couple of problems with it. So if a person has an interim federal health number, so even though they'd be considered insured, they're still excluded with the ICS data. So, but that's usually just a time period that people have an interim federal health, and theoretically they're supposed to be insured after that. But there's a whole bunch of barriers that people have in getting health card numbers sometimes that Angela could probably speak to. And so absolutely, once they have a health card number, the data gets all included, but there still are quite a few people that are uninsured, as I mentioned, like up to 56% in some CHCs.
Angela, did you want to speak to that briefly, just the barriers?
The barriers to securing becoming insured.
Mm-hmm.
Yeah. So you have, so in terms of, and I can just use the example of our community health center, Parkdale Queen West Community Health Center, located in Midwest Toronto. So we see a good portion of our community members who are uninsured, but who are homeless uninsured. So those are folks who could be eligible for OHIP, but who, because of a whole set of vulnerabilities and in terms of structural inequalities, are unsheltered and are therefore without in terms of their information. So one of the work that we then do is, as part of the team-based care, is basically run ID clinics where we support folks in becoming back into insured, in getting their documentation. So that's one group. But then you have folks who are, irregular immigration status, folks who are in terms of in the queue of becoming in terms of in status. And those are folks, we know we have folks who we see who have been here many years, undocumented, and that they will likely not get insured. And those are folks who still continue to need care, but those are also folks who also need to count somewhere in the system. And we have not yet figured out how to do that, which then makes it hard to then talk about what are the supports and the gaps in supports for uninsured population in relation to healthcare and healthcare services. So we can speak about anywhere from 300 to 500,000 people who are uninsured. But we have not been able to really kind of give more polish to that number, and I think that's a space where work is needed. And I think Jen responded to the linking of the data to somebody who is without IFH today and who is in the queue and who may get IFH and how that gets linked. But I would say there's a significant number of folks who are not captured and therefore who are out of care and out of care planning. And if there's something that we can do to address that, that's certainly needed.
Yeah, that's really important context, I think. And there's just one clarification question that came in, and that's, is that 56% you just mentioned individuals without OHIP only, but may have other forms of insurance, or do they have no insurance at all?
Yeah, they may have interim federal health coverage.
I see we're just about at time. So if I don't see any more questions, I think we may close here. But thank you so much to all of our speakers today. This was a very, very informative discussion, just allows us to dig a little bit deeper into that data and actually see some of the real world applications of that and the importance of engagement as well. Two very quick items for me just before we close. Our next session will be on the Canadian Community Health Survey data, or CCHS data. That'll be happening in June. And then finally, we also are continuing to promote sessions for guidance on using social variables at ICS. So we do have some spots open for May and August. If you want to learn more, feel free to reach out to us. But thank you again to all of our speakers. Thank you for everyone attending today, and hope you have a wonderful afternoon.
Thank you.